Chronic diarrhea. Case. Dear Doctor. Mr. Darren Weaver, aged 24 years. Thank you for seeing this married man with no significant past medical history who complains of a 6-month history of diarrhea with blood mixed in with the stool. Problems started after he ate a dodgy meal and he assumed that they were infective, but matters have not improved. He has lost some weight and also complains of arthralgia. What do you think is responsible for these problems? Yours sincerely. Introduction. This man is most likely to have idiopathic inflammatory bowel disease, IBD, but it is important to exclude chronic infection and to consider other causes of chronic diarrhea. Table 3. In older patients, intestinal neoplasia and paradoxical overflow diarrhea caused by chronic constipation must not be forgotten, and always check that the patient does actually have diarrhea, i.e. increased daily stool volume. NB. Celiac disease is common and may present subtly with chronic diarrhea and vague malaise. History of the presenting problem. Patients assign their own meaning to technical terms, so always check what they mean by diarrhea, constipation, runs, accident, etc. Relating to the diarrhea. Stool frequency and volume, how often, how much and for how long? Be precise. How many times have you opened your bowels since you woke up this morning? How many times did you get up last night? Is it a little or a lot on each occasion? Other markers of severity would be if the patient feels faint or unwell when passing stool, or if there is undigested food in the stool. Associated symptoms. Ask about urgency, pain on defecation, tenesmus, passage of mucus or pus, bleeding. If there is rectal bleeding, is the blood passed freely, sometimes without any stool? Is it mixed with the stool? Is it only present on the toilet paper when the anus is wiped, suggesting piles? Exclude steatorrhea. Ask if the stool is bulky and light-colored, floats on the water in the toilet, and or has an offensive odor. Other symptoms. Systemic. In any patient presenting with chronic diarrhea, ask specific questions to determine if there has been weight loss or a systemic response revealed by fevers and sweats. Nonspecific malaise, with or without weight loss, is frequently present in uncomplicated ulcerative colitis and celiac disease. Weight loss, fever, night sweats and malaise are usually prominent in patients with Crohn's disease and intestinal tuberculosis. Pain, cramping abdominal pain often accompanies diarrhea of any cause. Deep-seated abdominal pain should alert to the possibility of Crohn's disease, intestinal tuberculosis, and neoplasia. Pain suggesting pancreatitis or cholelithiasis may provide a clue to the cause of steatorrhea. Other relevant history. Age is important in that neoplasia is very unlikely in a young patient such as this man. IBD and celiac disease, on the other hand, can present at any age. Tuberculosis is particularly common in Asia and Africa. The rare condition of Whipple's disease occurs almost exclusively in older men, and microscopic colitis occurs typically in older women. Apart from a positive family history, there are no known risk factors for IBD, although in some patients it appears to be triggered by an episode of infectious colitis. The main risks for chronic pancreatitis are excess alcohol use and cholelithiasis, although patients heterozygous for the cystic fibrosis mutation may be at increased risk of idiopathic chronic pancreatitis. Direct questions are usually needed to address possible endocrine disorders, carcinoid syndrome, HIV disease, travel. When did you last go abroad? How long were you there? What were you doing? And the time before that, diet, and laxative and other drug use. Arthralgia, arthritis, skin rashes, and visual symptoms can be associated with IBD. Plan for investigation and management. Examination of the stool. All patients should have stool examined for bacterial pathogens and for the ova, cysts, and adult forms of various parasites. Amoebae may be difficult to detect if a fresh, hot, stool sample is not examined. If the test is available, estimation of fecal leukocytes is invaluable in distinguishing inflammatory disease from other causes of diarrhea. In some cases it is necessary to measure the stool volume over a 24-hour period or to estimate fecal fat excretion over a 72-hour period. NB. Infective causes must be excluded in all cases of chronic diarrhea. Endoscopy and imaging. Rigid sigmoidoscopy, rectal involvement is almost universal in ulcerative colitis, while the rectum may be spared completely in Crohn's disease. Bleeding, ulceration and a mucopurulent exudate may be seen, although in less severe inflammation there may simply be loss of vascular patterns and a granular friable mucosa. Biopsies should be taken for histological examination. Colonoscopy allows direct visualization of the entire colonic mucosa and in many cases allows examination and biopsy of the terminal ileum. It should be performed in all patients with suspected colitis or Crohn's disease and may be the most direct way of establishing a diagnosis in other patients. Fig. 4. Plain abdominal radiograph. Visible dilatation of the large intestine may presage perforation and is an emergency, although this is most unlikely to be seen in an outpatient setting. Pancreatic calcification may help establish a diagnosis of chronic pancreatitis. Blood tests. Routine blood tests include FBC, anemia, leukocytosis, electrolytes, hypokaliemia, renal and liver, hypoalbuminemia, and bone profile, inflammatory markers, iron, ferritin, folic acid, and vitamin B12, clotting screen, anti-tissue transglutaminase antibodies, virtually diagnostic of celiac disease, although the test may be falsely negative in patients with IgA deficiency. NB. Raised systemic inflammatory markers are unusual in ulcerative colitis unless the disease is severe, but Crohn's disease can produce a marked systemic response with few clinical signs. Assessment and management of nutrition is a key feature of looking after patients with chronic diarrhea, particularly those with IBD with small intestinal involvement. Iron, folate, and B12 are absorbed preferentially in different parts of the small intestine and abnormalities may provide clues to localization of disease processes. In malabsorption due to pancreatic and biliary disease, fat and fat-soluble vitamin absorption are most affected. Serum calcium, vitamin D, and prothrombin time, which is prolonged by vitamin K deficiency, are informative in these cases. In rare cases it may be necessary to proceed to test fasting gut hormone profiles to look for abnormal concentrations of gastrin, glucagon, and vasoactive intestinal peptide, VIP. The carcinoid syndrome may be diagnosed by increased urinary excretion of 5-hydroxyindoleacetic acid. Management. Specific management will depend on precise diagnosis. Attention to nutrition is required in all cases of chronic diarrheal illness. NB. Intercurrent infectious diarrhea should always be considered, even in patients with known IBD, particularly before starting immunosuppression. NB. The management of patients with IBD requires a long-term multidisciplinary approach, including dietitians, specialist nurses, physicians and surgeons. Differential diagnosis of chronic diarrhea. Intestinal inflammation. Idiopathic IBD, ulcerative colitis, Crohn's disease. Microscopic, lymphocytic, or collagenous colitis NSAID enteropathy. Intestinal tuberculosis, which may be clinically indistinguishable from Crohn's disease. Radiation enteritis, colitis, and proctitis. Chronic infectious diarrhea. In HIV infection and other immunocompromised individuals, organisms frequently encountered are Microsporidia and Cryptosporidium. Cytomegalovirus and atypical mycobacterial infections may occur. It is debatable whether a specific HIV enteropathy exists as a separate entity. Some enteric infections such as giardiasis and amoebiasis may produce prolonged symptoms even in immunocompetent individuals. Tropical sprue Whipple's disease. Clostridium difficile-related diarrhea is usually acute, but may be chronic and relapsing. Intestinal neoplasia. Intestinal lymphoma may complicate celiac disease and chronic immunosuppressive therapy. Adenomas, particularly secretory villus adenomas of the colon, can produce a secretory diarrhea. Obstructing neoplastic lesions may produce chronic constipation and paradoxical overflow diarrhea. Malabsorption. Pancreatic insufficiency, e.g. chronic pancreatitis celiac disease. Bacterial overgrowth. Bile salt diarrhea due to ileal disease and reduced absorption of bile salts. Systemic disorders and drug-related diarrhea. Thyrotoxicosis. Secretory neuroendocrine tumors, such as carcinoid, pheochromocytoma, VIPoma. Diarrhea is a frequent side effect of some drugs, such as alsalazine, mycophenolate mofetil, misoprostol, colchicine, and antibiotics. 1. Factitious or fictitious. Laxative abuse.